Hey Rich, how you doing? How's your day going?
Going great, Mark. Good to see you, buddy. I just finished up with a busy morning, and I'm glad to take some time off to hang out with you and talk.
Sounds good. Well, welcome to our first podcast. So,
I,
uh, hopefully this will go well. I'm sure it will.
okay.
So, the podcast is really airway focused dentistry, and with my good friend and brother and a partner in crime for going back to dental school, classmate, roommate, Richard G. Stevenson, and I am Mark Cruz. Rich, tell us a little bit about yourself, your career path before we launch into our topics.
Well, like you said, Mark, I was your classmate. We graduated from UCLA in 1986. I didn't think I was going to go to dental school at first. I thought I was going to go to medical school or something like that. And I think you have a similar story. But we ended up in dentistry, and we did pretty well, all things considered. We actually became good friends and started a practice together. And we did that for, I think it was a total of 6 or 7 years, 7 years. But somewhere along the way, I got the bug to teach. And one of my dental assistants said, "Hey, Dr. Stevenson, you want to apply for this part-time job at UCLA? We get to teach." I did. I got the job. I started teaching part-time, and one thing led to another. And before you knew it, I found myself in full-time academics. I spent 26 years teaching at UCLA. I mean, what a great run that was. I got to meet and become friends with some of the neatest people and in dental education and all those students. But as things happen, I was ready to move on, and so I left the academics to keep on doing academics, and that's what I'm doing right now. I'm teaching dentists in my teaching center here in San Dimas, California, and I also have a private practice, and I get to see patients of all walks of life. But primarily, I focus on complex cases, things that other people have a little bit of insecurity about treating. Uh, Problems with bite, problems with aesthetics, things of that nature, and even some implants. So that's kind of my story, man. It's been quite a career. I still love dentistry like you, and I'm also super excited about kind of, here we are in the last lap of a mile race, and we find ourselves running together again. And we started at the starting blocks. Here we are running together again, and I'm really excited about this next journey for us.
Yeah, I am too. I always believe that there are no coincidences. Things happen for a reason. And, taking the time to discern in retrospect, you really start connecting the dots that, yeah, that's kind of scary how that worked out. It wasn't a coincidence. And I know, we started a practice from scratch, probably at the worst time in dentistry to start a practice. There was a great recession if you remember. And we didn't have one patient. I remember I was in dental school. I was getting a call from the general contractor, asking me where to put the junction boxes in this suite. There a building that they were just building. This our suite wasn't even ready. I'm going, what the heck do I know about that? But I was excited, right?
Yeah,
And it was just a natural that I would invite you, and together we started this practice. And I think it's interesting that, yes, we practiced together and I relished those years. I think it was the first 6 years. There's a lot that we learned. If you look back in your career after 40 years, it just like rolls off the tongue so easily. It scares me. At a time that we both should probably be thinking about retiring or retired, like a lot of people, I think we're just getting going.
I
I
agree.
think, being able to blur the line between work and play is just a blessing. But anyway, um, so then you went off to academics, and um, we were both in a study group that we started, and our mentor Warren Johnson had suggested to me that perhaps I should teach as well. And as boomers, okay, we kind of follow our mentors. It's maybe a little different today, not a good or a bad, it's just an is. And so I
Right.
did that. but I also relished the opportunity to be able to do research, always looking and seeking for the truth. And but my real job was private practice, whereas your real job was full-time teaching. And like you said, you did that 26 years, and then you're back into private practice, but then also doing teaching. So I think you bring this richness to those that come to your courses that you're not an ivory tower clinician. You actually can do it. For me, I always believe that there's this tension between academia and clinical practice, where the joke of those that can't do teach. Well, you're the anathema of that, obviously, and for me, I've just learned a lot from that. And then coming back and circling back, and what brought us together is this boom that's going on in Airway, and so I'm just going to kind of pivot now our conversation a little bit about like our core competences, what we're about, and what I learned probably starting around 2008, 2009, I started, connecting some dots. And it was during a time where I was recovering. I was really sick, if you remember. And I had to take like 6 months from private practice. And I had the time, and I started connecting some dots having to do with what we do as dentists. And at the time, our profession was really focused a lot on sleep and sleep appliances, sleep group solutions. I had no interest in that. I was a restorative dentist focused on complex peri-pros interdisciplinary care. And making sleep appliances had no appeal to me. And so I kind of recoiled from that, and ironically came back in a different form because I'm going to argue that most sleeping problems are actually breathing problems. It's just that at night, it's when it rears its ugly head. So from that, I started giving, small little study club lectures and courses on Airway. I was only focused on the adult patient. I hadn't connected the dots till my son's situation when he's about 4 years of age, and I'm not going to get into it now, where the problem starts, how early it starts. And so this is what we call the Airway timeline that we'll talk about maybe perhaps in one of our other podcasts. But that really got me excited because it gave a completely different context to what I had been doing up to that point, 25, almost 30 years in practice. That,
Can I interject?
yeah,
Because
please.
what you just said was so great, the timeline. I heard this recently, and it was really interesting, and it really speaks to this timeline of Airway. What is the first thing a baby does when they're born? Is they inspire, and
Yeah.
then they wail their big cry. And what is the last thing a person on their dying bed does? They expire,
Exhale.
right? I mean, so the inspiration and the expiration. And I thought, wow, it starts with a breath in and it finishes with a breath out. And
Isn't that
it's
funny? Yes.
so critical, right? So
Yeah.
I mean, it's so apropos. And you were mentioning you noticed it in your son that was 4 years old at the time, but of course, you and I both know that the problem can potentially start at the very, very beginning.
Yes. In utero,
And
actually, yeah, exactly. In the beginning of the third trimester of life is something that in one of our podcasts we'll talk about fetal and maternal issues that really are just starting to bubble up. And so we've got so many podcasts to talk about so many different things. But for this introductory podcast, a little background on us, what brings us together, and I'm just really, it's like fantastic that my good friend that I classmate took different steps and paths in our careers and were brought together, and I'm very, very excited about that. Which brings us to um, two topics in the format of our podcasts. We'll typically cover two topics, and then after we cover those two topics, Then we'll talk a little bit about what's the learning moment for the week. And then we'll end with the mail, which may be either chatter that's going on in social media, Instagram, X, or whatever. And then we'll end it. I think we'll try to be disciplined for our followers to keep it to an hour. So it's a nice, neat, clean hour because it'd be very easy to go down rabbit holes and spend an hour and a half in making long form even longer. So we want to make this in a format that's very easy to digest, just 1 hour a week. And so what I would like to talk about right now, Rich, and have you kick it off is tell the audience. Let's just talk between ourselves the current challenges in dental education. And here, coming from a professor, clinical professor, someone who ran the largest department in the dental school, and I'm going to say the best dental school in the country at UCLA, you ran that largest, biggest department, and really dealt both undergraduate and graduate programs. Being um, mired, if you will, in that environment, what do you see now in retrospect the current challenges are in dental education, knowing that you do a lot of continuing education after all that? But tell us a little bit about that.
Well, thanks, Mark. I would like to say that um, continuing education currently is in trouble and they're suffering. And I'm not sure they know how much suffering they're really enduring at the moment. And it's multifactorial. The students are not getting the same type of education that we got, which was very deep and it was highly technical, but it also was a lot of critical thinking, a lot of MacGyvering, if you will, of how to make things work. We had a completely different educational experience than the students today, and there have been many things that have influenced that change. One of them was a report that was written by the Institute of Medicine, basically calling out dental education for being too technical and spending too much time on teaching skills development, and it wasn't forward thinking, wasn't progressive enough. And that report had a major impact on dental education. And at first, we were all a little bit excited about these changes. And then what we found out is that we just didn't know what we didn't know. And the emphasis in dental education has shifted away from learning how to use your hands at the highest level to maybe being aware of different cultures, cultural, awareness, healthcare literacy, a lot of, deep dives into the science of things, which is all wonderful. But ultimately, in 4 years, unlike medical school, unlike medical school. The 4 years of dental school is not only a medical program, but it's also a surgeon program. And I think what's happened is the dental schools have forgotten that. And they have to produce a dentist that is not just competent, but excellent. And when we graduated, it was not about competency, it was about excellence. It was clear to everyone that got out of that program, rocked across that stage and got their diploma, that we had gone down the pathway of excellence. We were inspired by our educators. We knew how to do the work. And actually, our level of confidence about our own competence was high. It was high and it was also accurate. So if you were to objectively look at the graduating class of 1986, for example, we would say 99% of us felt competent. And our faculty would say, that's true, you are. In fact, you're better. Today, it's the opposite. The students are graduating with a disconnect of what they are able to do compared to what is being measured by objective parties. For example, there's a paper that just got published this month in Operative Dentistry talking about the disconnect between core competencies and abilities in performing the surgical things we do day in, day out, and from the student's perspective, and what the mentors see happening. And it's a very critical article, and it's basically saying dental education is broken. That you're graduating someone that doesn't know what they don't know. And I think that we knew what we didn't know when we graduated to a large extent. We knew there were areas we need to take a look at, but and that's kind of a safe graduate. That's a introspective, self-aware kind of surgeon. That's the kind of surgeon you want to have. Someone that's not afraid to say, I don't know it, but I'm going to find out. Today, you're getting a student that says, hey, I got this. But in actuality, they don't. And that to me is one of the most frightening things that we have going on right now. The worst thing we could have done was try to turn dental education into medical education. Remember, in medical school, you go to 4 years. That's just the beginning. If you want to be a surgeon, you got to go into your training. And your training is extensive, and you have the opportunity to train your hands. So most surgeons get out of medical school, they're going to have at least 10 years of training before they're actually working on patients in a independent manner. So I'm very, very concerned. Part of it was this report from the Institute of Medicine. Part of it, unfortunately, were the echo chamber of this idea that everyone's going to develop these competency programs and everyone's going to be competent. But the sad thing is, competency, as I mentioned earlier, meant excellence to us. It really did. But competency today means something entirely different. It means barely passing. And I don't think the public today wants a barely passing surgeon working on them. I mean, let's remember the DDS, the S in DDS means surgeon, means surgery, right? So if you're a doctor of surgery, you better know your stuff. And what I found in my courses here in education is an enormous lack of ability in the recent graduates to perform things that you and I take for granted when we graduated. And
Yeah.
the quality of the graduates is awesome. The quality of the graduates today, in terms of their intellect, their motivation, their readiness to do the right thing, it's all there. But where are the infrastructures in dental schools to push for excellence? If you mention the word excellence in dental school, it's almost like you're an outsider. How can you say such a word? We're just focusing on competence. And it's to me, it was kind of disheartening. And I got to tell you, that's one of the reasons why I had to get out, because I could not train my students in excellence without singling myself out as a target for many things. It's politically not very popular. It is makes other people look bad. And when you engage students and you inspire them, you try to teach them at a higher level, uh, you kind of stand out a little bit. The other big problem, I think, other than money, because money is always a problem, is how do you train faculty to be consistent? How do you calibrate them? You get all these part-time faculty, because part-time faculty are cheap. Dental schools, instead of hiring an amazing full-time faculty that takes you under his wing or her wing and shows you how to do things at the highest level, they'll go hire 10 people for the price of one faculty member. So there's bang for the buck, and that kind of keeps the machine running. Also, in this era of social media and I would say very sophisticated messaging from publications and emails from the academic institutions in dentistry, they make everything look wonderful. No one knows the better. All the alums think everything's the way it was, but just more modern. And what we don't realize, it's not like that at all. Because the messaging that's coming out by professionals that know exactly how to push the right buttons on their alumni to get donations, that know how to push the buttons in the public sector, they're giving this image that things are never been better. Look at all of our accomplishments. Look at all the things we've done. But when you look down behind the curtain and you pull all that away and you look at what's really being produced out of dental school, it's not the same. I'll give you one last anecdote and then I'm going to hand it over to you. The the class of 2022 at UCLA graduated a fourth year dental student that had not performed a single crown restoration. Not a single one. He's a DDS. You know that you and we felt ashamed if we did less than 50, and we did all the lab work too. The kids today, I say kids, they're young professionals, but they don't do their own lab work. The administration is soft. They don't want to upset parents. They want to push them through the program. And I don't think the public is being served in the best light possible. And that's kind of a common theme for us, Mark, is that, you know, our whole vision in Airway is serving the public at the highest level. Because that's what it boils down to. It's not the kind of car you drive or the home you live in or and all those wonderful things that dentistry can give us. It's about what have we done that's actually helped humankind? What have we done that has made a measurable positive impact on the people that we serve? And I'm really afraid for the future graduates unless they find postdoctoral institutions like ours, like what you and I are doing. This is going to make a huge impact, and I'm excited about that because all hope is not lost. I think we have a way out. We do, and that is through sophisticated, real world, proper education, holding people to the highest level. You know what they say when they finish our courses? They love it. They absolutely are attracted to it. They want this desperately because they never got it in school, and we
Mhm.
got it all the time. So
Yeah.
it's just a huge difference.
Yeah, I mean, I think in summer, everything that you said is really an institutional problem, and I would just say to put like a positive spin on things that I could tell you that there is not a more exciting time to be a dentist right now with
Agreed.
what we're learning in Airway, what the role of the dentist is, which we'll talk a little bit about. But yeah, I think the system is broken. And if you remember at the time that we graduated, it was just starting that the average dental student will go on to a specialty program. Pretty much now, I think all of the dental class, they feel they have to go and do a 1 or 2 year general practice residency just to become competent. I remember talking to one of my colleagues who's a program director at Loma Linda for grad pros at the time said, we get our residents in and we spend the first 6 months just remediating,
Yeah,
just to get them to where they're at the point where we would otherwise have accepted them to start their curriculum. And so I don't blame that necessarily on the student. It's really the institution because I
right.
think we could argue that the competitiveness to get into dental school in some regards is even higher than in medical school now. I
Oh,
mean,
absolutely.
people are just trying to get in, and they're really super bright, the creme de la creme. And I just think the institution just kind of blows it. And I think part of it is that the dean has less time to focus on education and more time on fundraising, getting endowments, getting money, research dollars. So um, I'm not going to blame any one person. It's just things are kind of falling apart. And these graduates are feeding a system that's overtaken our profession called the dental service organizations, right? You don't have very many solo practices, entrepreneurial solo practices that really demanded excellence to be successful. Now you just get plugged and played as an employee, where you have a bean counter saying this is what you have to do, and so I am concerned about that. Now add to that Airway, which really focuses more on the patient attached to the teeth. We really understand that's a multifaceted problem that requires a much deeper understanding. And I'll say, Richard, that I've been giving these courses for a long time, 15 years or so. And the people
You're
who,
you're like the first guy to come out that
yes,
actually started
yeah,
talking about airway, about breathing,
yes,
and about how that impacts everything. And up until that point, it was just all about sleep
sleep.
related things
It was about
and
sleep.
devices that you can give people.
right?
to open up their airway and things like this, but mainly for sleep. So
Yeah, and
yeah,
people, yeah, and I had a lot of arrows in my back. They thought I was crazy. There's no evidence, and I'm talking about the gurus in our profession that are now the experts, right? And so at the time, I was just kind of doing my thing. And I remember Keith Thornton, who's really the guy that started the whole thing on dental sleep medicine with oral appliances very, very early on, fought for our profession with medicine on, whose domain is this in. And he came to one of my courses early on, and after one of the days of lectures, came up to me, and said, Mark, it's too late for me, but I could tell you, because I'm just about, fabricating these appliances more efficiently, better, et cetera, et cetera. But everything that you're talking about, root cause and craniofacial growth and development and breathing, that's the future. That's where we need to go. And so I would have pearls like that from people like that reassured me that I was on the same path when I was hearing a lot of chatter that there was no evidence. And interestingly, as a dentist, most of the encouragement came from physicians. I mean, I'm talking about really well-known physicians that said, this is what really needs to happen. One of them was Kristen Guilleminault, who started the specialty of sleep medicine. And it says, really, this is in the domain of dentistry because the problem is more about the facial skeleton, right? And the function associated with that, that of course leads to dental treatment and all the things that we do. But most dentists, really, when you think about it, like you said, we run an outpatient surgical center. It's
oh, we're
different
like a
than
hospital.
an internist, right?
Yeah, yeah,
And the thing about um, uh, airway dentistry is that you now get reconnected a little bit more like a physician in your histories, less procedurally driven, although we have a huge toolbox to really understand the problem, getting quantitative, qualitative data, being outcomes measured, being patient-centric, all the things that we teach in our courses. And so my concern as it pertains to airway education is that now there are a lot of players that are jumping in and are experts in teaching courses. There are a lot of corporations that are selling widgets as if that's the answer. And, I would talk to Barry Rayfield, who's also one of our faculty teaching partners for a long time, would say to me early on when people were starting to, jump in, who didn't think really had a lot of the knowledge. They have it a little bit, but they were out there in social media and getting a lot of attention. And he says, look, Mark, McDonald's didn't go out of business because Burger King opened a store across the street. And so the good news is that we're now in the profession that it's already here. There's
right.
no question. People aren't arguing with it. Even medicine is jumping in. We know that airway is the future. And, on another separate broadcast podcast, what we're going to have to do is really spend a lot of time is what does it mean to be airway? And I'm going to just give you a hint. It doesn't mean palatal expansion. It doesn't
Correct.
mean using an appliance like a tooth pillow or a myo brace or, an infant trainer. Okay,
Right.
that's just a tool. It's not widget driven. It's doctor driven, which means that you have to have the mind of a doctor and doing that. So I would say in wrapping up, this second of our topic, on education, or actually the first topic on dental education is that there are a lot of challenges and we're here to meet that challenge and for really for the public at large, not for ourselves, really to contribute the role of the dentist beyond just looking at teeth, gums, and joints. I think that's been a mistake, and we're not even doing that very well. Digital
Correct.
workflows only take us, and technology only take us so far. We've turned into high tech, low touch. And I think that in going into this, we have to be high tech, high touch as well. And there's a balance there. Our second topic really kind of is leading us into the second topic, which is, the problems in healthcare. which are related, right? So it's an institutional problem, like in education, which is where it's the incubator, if you will, but then you get out and now you've got healthcare in general as an institution. There are clearly many, many problems. If you look statistically, it's absolutely irrefutable that our country's getting sicker and sicker, and it's unsustainable, the cost, because in an allopathic model, we are incentivized to address signs and symptoms without getting into root cause. No, 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 don't tell me why. I just want the magic pill. I want the magic device. And it's not to say that we can't use that, but if that's our first step in addressing the patient, and we've got 7 minutes to solve this problem, move on to the next patient, I think we've failed. And in fact, the public at large is frustrated. You know, the United States in our health, we don't even rank in the top 50 of all the countries in the world in health. And yet we pay over twice as much as any other country. And so something has to stop. And it does start with education. But we also have to re-educate a public that's been programmed to having the instant solution. And so there are a lot of companies coming in with supplements. It's $1 billion company that industry that is trying to solve this problem. I'm so excited about the Maha movement, but the problem is I'm going to say that it's not the food supply by itself that's causing the problem. In fact, what I'm going to say that our food supply and the food industry that everyone already is understanding that is a problem, that is the fuel. It's not the fire. It actually is airway is the fire, and these other factors are white gas. It's white fuel thrown in that fire to stoke it. So yes, we have to address that problem, but we really need to point our hose at the base of that flame to put it out and really pivot towards a more of a wellness model that actually fosters wellness. And just to define wellness is not the same as not being sick. So as I tell my patients, being well is different than not being sick. So patients think, well, if I'm not in pain, I'm okay. I'm only going to go to the doctor when I have my symptom du jour. And of course, the pharmaceutical companies are very quick to have a chemical solution for every symptom, right? We're getting more and more sophisticated in that regard. And I'm not here to pick a fight and say that's wrong per se, because in the United States, we're brilliant at that. We do it better than any country in the world, but we've kind of taken our eye off the ball, if you will. And we need to kind of go back to etiology and root cause. And so, with that said, I think that's going to be the solution to this overarching health problem that we have in the United States. What are your thoughts?
Well, gosh, I can't agree more. I got to tell you that there's a few things about the current healthcare system. And by the way, before I get into my little story, um, please tell everyone what allopathic means, because we know what it means, but in simple terms, what does that mean?
Well, allopathic is basically the system that was started after 1910 when Abraham Flexner, under the aegis of the Carnegie Foundation, basically went to Congress and said, "Hey, look, there are all these medical schools that are teaching medicine kind of like an apprenticeship and doing things like using leeches and bleeding patients and didn't really have a lot of science or evidence really to support it. And so the Carnegie Foundation provided the funding for Abraham Flexner to really do an analysis. And at the end of that report, essentially 90% of existing medical schools closed. And so that was the beginning of the allopathic testing. It was a Germanic model that was being taught in Germany that was more science-based, where you'd have the medical students around a surgeon that would have a body, and they'd start looking at the anatomy, and they'd start looking at more of a science-based approach, right? In its very, very early stages,
Right.
versus kind of an apothecary. Try this snake oil and see if it makes you feel better, and you're not selling this on off of a chuck wagon to help people, right? So allopathic medicine started at that point. That was over 100 years ago, right? 1910. About 30 years later, Geese did the same thing for dentistry. So in this age of information since, we haven't revisited dental and medical education. So that's its own topic. That's
Yeah.
where the problem starts. But yeah, that's an allopathic. Homeopathic is maybe the other side of that coin, which is more Eastern medicine that does have a lot of validity, but we don't understand it as much in the West, so we tend to poo-poo it. So I'm going to
Mhm.
say that there's a combination therein, and that we must understand that there's a lot less than we know than what we don't that we don't know than what we know, and so we have to come in with a bit of humility. And I could tell you in the allopathic system that now, as of about 2000 and the mid 2000s, turned into the evidence-based approach. I was in early on at UCLA in
Right.
bringing on a concept that at the time was being fought. What do you mean? In my
Yeah.
hands, this is the way we should do it.
Right.
So, Sackett and McMaster University wrote the book, Evidence-Based Medicine, that transformed medicine as well. And I'm not going to get into the definition, but to answer your question, that's essentially what the allopathic model is. But there are a lot of problems with it. And it tends to lend itself to disease management and inefficiencies.
I agree. And I also, and this is a political hot topic, but access to care uh, is it's a major issue for anyone. And as a new holder of the Medicare card, I know you got one too. And by the way, you have no choice. You have to get it and you have to pay. And it's not free, I found out, which is a big surprise to me. I'm thinking, my gosh, I played so much into the system and then they reward you with a monthly bill. But anyway, you have to advocate for yourself these days so much. And, like for example, I was feeling really fatigued all the time. I mean, I had dark circles under my eyes. I was moody. I didn't know what was wrong with me. I was actually just miserable. It got so bad that it was no longer the new normal. It became unnormal. And so I went to see my primary care physician at UCLA, a great guy, brilliant, highly regarded, highly researched. And I had to almost lie and exaggerate my symptoms to get a referral to a pulmonologist. When I walked into the pulmonologist's office, they're like, "What are you doing here? You don't fit the phenotype of someone with a breathing or a sleep problem or whatever." And so I had to once again exaggerate my symptoms. And I was wearing the white UCLA coat with the logo on it and with the badge that allows me even to walk into the OR and anywhere in the school. And I had to kind of use that posture and that insistence that something happened, that reluctantly I was referred to a sleep study. Now, this is way back before you were even really on board with most of what you're doing and what we're doing. But my gosh, it's like, and then of course I get the sleep study on it, and they find out that I'm a train wreck, and that's with a really crude sleep study. Today, with better studies, as you and I recommend, we get better data. But the point was, how in the world is the average guy that's just dealing with these kinds of problems going to get any help? I mean, that's a huge problem
Hey,
with the.
ChatGPT, man. ChatGPT.
There you go.
So here, Claude, Opus. Okay, so you're right, and so all these things you just talked about is going to be the foundation of the discussions we have on the podcast, and it's
Right.
rich. I mean, we could go on for
Real.
hours, and I think we need to. And as
Yeah.
our followers, bringing up topics and questions. I really look forward to it because I'm chomping at the bit and really taking deep dives on a lot of this because ultimately what we want to do is not say that this is the way it has to be done, but rather to start a conversation to ask different questions, to think about it differently. And we could have reasonable conversations about the challenge in healthcare, the challenges, it's huge. What percentage of our gross national product is spent on healthcare? It's a growth industry. And you're right, the problem is not access to care, it's the kind of care. And that's where my focus is with policymakers, why, I'm vying to get to Washington, D.C. to be able to talk to policymakers on next Thursday. I'm going to be speaking. I got asked to speak at to a group where they're going to have U.S. senators, congressmen, policymakers, people from superintendents of school. They really want to learn about this as it pertains to kids' health, ADD, ADHD, breathing, and all those things. So, and the reason why I'm in there because the CEO that had invited me to come to that said, "Well, how many colleagues are you going to have?" I said, "I'm not interested in having." Other dentists, even necessarily physicians, come to that. I'm done with that. Right now, I want to go straight to the policymakers because we need to increase access to care to these families on for medical reasons while we're doing dental treatment to fix their kids, to cut the cost of care down for chronic disease later on down in the future. Because otherwise, we're going to fall off the cliff. And this is what the whole podcast is going to be about, just as a teaser. And so I think maybe we should wrap up a little bit here, talking a little bit about this week's learning moment. And so tell me what the learning moment this week was for you.
Well, actually, I had an airway patient. She asked me some really great. I had a patient that happened to have an airway issue. A wonderful, wonderful patient, and she said, I just want to dig a little deeper. I'm the kind of person that likes to go a little further into topics, particularly when it relates to my own health. 61 years old, unbelievably healthy, she's a vegan. Everything she does is very carefully planned out. She's on no medications, has no systemic disease, but is chronically fatigued, cold hands, cold feet, fragmented sleep. She's actually kind of miserable within this outer shell of doing everything perfect. So when she asked me for more information, I said, there's some pretty good YouTube videos out there that I think you might be interested in. So I was actually looking for a TED Talk. I couldn't find the darn thing, but I was looking for a TED Talk where a female dentist talks about all the reasons for airway issues and how we need to be looking at our kids differently. And I thought it was really good. And I saw it, but I couldn't find the darn thing. But I did find a video on YouTube that was part of a podcast on health. And it was an orthodontist talking about the problems with children. And she could look at children from just a distance and know immediately that they have airway problems, which you and I know is totally true, 100%. We diagnose people when they walk in the office within seconds. I diagnose actors and actresses thinking, gosh, I wish I could go talk to them. I could change their life. But anyway, she's going through this whole spiel, and she's quite animated and articulate. But the bottom line was it always sort of focused on a widget, and I thought that it would. I didn't share that video with my patient because it would give her the wrong impression. But I did share with you, Mark, and the I think the great learning moment here is that there's a lot of chatter out there. There's a lot of stuff you get in your inbox, and if you really boil it down to what's going on, it's about a thing. It's about a thing. And that is so not what we're about, but I thought it's something maybe you can talk a lot, reflect on. Give me your feedback on that video. I mean, not that we're
Yeah,
not throwing anyone under the bus, because I'd rather have people doing the things than doing nothing,
right.
right?
Yeah. Well, that's right. And so I I've just learned to get better at not getting my amygdala all up in arms, if you will, hijacked.
You have.
So I woke up, and I looked at, you had sent me that text, and I started looking at that YouTube video, and it was mixed emotions. I was excited in that here we have somebody talking to a very big crowd
Right,
that was very influential, that was talking about, breathing and sleep. But the other part of it is, as you listen to the whole thing, and this is just routine. This is just, I predict this with everything that I've been seeing the last number of years, is that it has shallow knowledge, shallow understanding that ends up being resulting in try this widget. So
right,
what we teach is agnostic. We teach about being a doctor and understanding all the tools that we have in the tool chest, to be able to do what we need to do. And my concern is that we don't want to practice that is about using just a shovel, a spade, or a rake. You have to be able to use all of them, but you first have to really understand the problem. So in that particular YouTube, my lesson in it was, first of all, receiving it from you, seeing where you are and saying, see, I've been telling you, this is what's going on. And really, it's inspired us to do what we're doing here, to address that. I don't say that that person is doing anything wrong. It's great that at least she's starting the conversation. My hope would be that she would actually come to one of our courses, because I
wow,
could tell you in 15 years of doing these courses, and I was going to say earlier, the participants in my courses through the years typically were mid to late career. And 100% of the time, and many of them who super credentialed, very respected, would walk away saying, "Oh my gosh, I cannot believe I did not know this before." It puts a complete different understanding on things that I've been doing for 35 years, 30 years, 25 years, 40 years. I have to start doing Airway, and they say, "No, no, no. Airway is not a specialty. It's not either or, it's and. It's just a way of thinking about what we do as dentists, with more of a medical foundation, if you will, getting us back to being the doctor versus the mechanic." So I think that was my lesson of the week, is just continue to see what's out there, and it just got me excited. So yeah, thanks for sending that and sharing
of
that with me.
course, yeah.
Yeah.
Yeah. And I was thinking also about my the courses that I typically teach are really heavily focused in restorative dentistry and diagnosis and single tooth and multiple tooth dentistry, implantology, basically all the stuff that we do with our hands that really have nothing to do with what we're talking about here on the podcast, but they do in a way, don't they? Because we're not going to stop being dentists. We're going to always have to know how to deal with patients after we've taken care of their underlying disease and their condition. We're going to have to still restore them. But the way that it gets taught is going to have to be completely reworked. I'm in a process of I'm rebooting. Honestly, Mark, I cannot look at my curriculum with the same perspective anymore. I can't. It's not right. It's not right to teach something in a vacuum and compartmentalize without offering some higher understanding of why this tooth even has wear to begin with. And I think it would be a tragedy if dental educators, postgraduate dental educators, PROS programs, AGDs, GPRs, and private groups like ours don't pull this in. And it's got to be part of the future of dental education. Otherwise, we're lost. We've got to
Yeah,
do it.
I agree. I agree, because I want you to comment a little bit in closing here, on our curriculum. But I always joke and say, being involved in doing studies in dental materials, where we're testing flexural strength and fracture toughness, I
Yep.
came to the realization that's not really what we need. We don't need higher fracture toughness or flexural strength. We just need to get the patient to function the way they're supposed to function. And
Right.
they're breaking things because they're para-functioning or they're compensating, mostly due to an airway. No question about it. We'll get into end-tidal CO2, sleep bruxism. We'll get into all those issues and the science, and we're going to be very evidence-based in other podcasts. But with that, tell us a little bit about, in closing, briefly tell us a little bit about the exciting curriculum that we've put together and hope that we can grow.
Oh, I'm really excited about this. And I think, this is this is my opus, if you will. It's our opus. It's really something that is going to be we can look back on and be very, very happy, very proud that we've been able to bring this to dentistry. And what it is it's it's the Airway Mini Residency 3.0 in 2 sessions, 3 days each. So it's very bite sized, where the first session focuses on kind of understanding how to identify the problems and understand the nomenclature. There's a lot of new words and new science that we haven't really become familiar with, or that we have to re-remember from back when we were in school, and get you to the point where you could just stop with that one part of our program. Although I don't think you will want to, but you could stop and it would be profitable for you because you'd be able to perform diagnostic procedures at a higher level, refer to the right people, understand where to refer people, be a better provider for your community. It would be amazing if that's all you did. That alone would be huge. And then we have a second 3 days, which is to take that and put that into more of an implementation where you can start to stabilize and perform some interventions with these patients. And once again, profitable for the dentist, beneficial for the patient. It's a win-win-win. And so that could be done by anyone starting, could would hopefully want to do both sessions. And then we have a new phase of courses called the Airway Nexus. And I love the name because it really describes what we're talking about really well. And that is that we have all these spin-off courses that will provide our graduates of the first 2 courses, which is only 6 days, with opportunities to learn hands-on from one of the top the leading experts in the world on that topic, whether it be corticotomies and surgical procedures that may be required, or delivering appliances in the most optimal way, tracking things in children, understanding what kinds of devices apply to that population, how to implement that. And so we have all those breakout kind of courses, like spin-off courses that are also hands-on, usually packages 1, 2 days each only, which is amazing. And then finally, we shouldn't forget, we have an Airway clinical study group, which is mind-boggling, where you and I are working with our colleagues treating actual patients in our training center about every 6 to 8 weeks or so. We want to try to tighten that up and make it closer, which is kind of the high level of continuing if for those people who want more. And I just think that's just the tip of the iceberg, because it doesn't even include the intellectual property that we are absolutely excited about sharing. The videos, all your lectures, all the guest speakers. We have the most incredible information. And I don't want to steal your thunder, but Mark is the editor of what will be probably one of the most talked about books of the millennia, and in Airway, and that's coming out soon. So, uh, Mark, we're at the epicenter of the right thing, and I'm really excited about it. I've never felt this way about dental education in my entire 40 years as a dentist. And I hope that other people join us and see what kind of person and what kind of provider they can become as a result of interacting with us and seeing things in a different light.
Well, yeah, thanks. And I'll just end by saying that our secondary goals from um, uh, teaching our colleagues this is to teach the teachers.
Mm.
The problem is so huge that this really, I'm going to say, is going to be there's going to be a two-tier, excuse me, healthcare system. And this one is not even on the radar of corporate dentistry and medicine that actually gives more precise patient-centric treatment. But you cannot have a healthcare system unless you have an educated population of providers. And so our goal is to at least start having um, uh, a group that will grow of providers that will help us teach this and promulgate all over the country. And it transcends all of the specialties in dentistry, and I'll dare say, even in medicine. And so let's just end it till next week. Richard, thank you. I really enjoyed our first podcast here. I'm
That was
super
great.
excited about the future,
Thanks, Mark.
and so until then, we'll sign off and um, goodbye to everybody. We'll see you next week. Take care.